Welcome back to Rebelcast. This is episode 119, and I'm your host, Salim Razai. Back on June 1st of this year, one of my colleagues, Anand Swaminathan, wrote up a paper that was rather interesting called the CT First Trial. Should we pan CT after ROSC? This brought up a sort of debate/discussion between Scott Weingart, Swami, and myself that happened kind of behind the scenes, and we thought it was worthwhile to record a podcast going through each of those points one at a time. And so what you're about to hear is that discussion.
Welcome back to Rebel EM. We've got a great discussion today around the CT First article. Before I get into a little bit of the background on the article, though, let me introduce who we've got here with us. As always, we've got Salim Razai, the Rebel himself, and we've also got a visiting guest, one of our good friends, Scott Weingart at MCrit. Scott, welcome to Rebel.
Yeah, what a great pleasure to be here.
And Sal, thanks for doing this with us.
Yeah. I think this is I know you're going to introduce this paper. I want to say that we all pretty much agree, but I think it's worth discussing the paper because some people might take it at face value and might have
nuance.
A different conclusion.
Yeah, there's always nuance to these things. So let's get into the article. This was Branch and colleagues, Diagnostic Yield, Safety, and Outcomes of Head to Pelvis Sudden Death CT Imaging in Post-Arrest Care, the CT First study, published in Resuscitation in 2023. We have a full post going through this article, but as a bit of background, this is basically taking a patient who has had ROSC, and then before they go off to some other destination, unless you clearly know what caused this cardiac arrest, they're getting a head to stern CT. They're getting a full body CT scan looking for, can we find the etiology of this arrest, and can we guide care based on that? Again, you can go through the post and see what was kind of done here. So the primary outcome these guys were looking at was diagnostic yield of that sudden death CT scan in comparison to standard practice for identifying the cause of cardiac arrest. And what they found here was that the primary diagnosis was made in 92% of those who got that full body CT versus 75% in the group that didn't. That's a 17% difference. It was statistically significantly different. In the secondary outcomes, they looked at things like time to diagnosis. That was better in the group that got the full body CT scan. They also looked at mortality, and there was no difference in mortality. And I think that secondary outcome is part of where we have a little bit of a disagreement on how we interpret these findings. So Sal, you sent me over a couple of different points. Scott, I know that you have thoughts on the same ones. We'll start with those, and then we'll kind of go into other things. So let's start with timing. In this study, they said they wanted to get that full body CT done within 6 hours of return of spontaneous circulation. And Sal, you pointed out that a lot of patients that were excluded from the study, they were excluded because they couldn't get them to CT within 6 hours. So talk to me a little bit about why you think that limitation is important in how we interpret these results.
Yeah, I mean, so I look at this as there's a few things here. So the first thing is I want to start off by saying I'm not against doing the pan scan after getting ROSC, because I think there's a lot of times we don't know what the hell is going on as why they had their arrest. And I think this is the first thing to point out is this is a diagnostic study, right? Their primary outcome, what they were powered for was can we make more diagnoses, right? The mortality endpoint is secondary. It's hypothesis generating. And so my concern was a couple of things with the timing. The first is that there's so much chaos, so much going on in a cardiac arrest that we need to do all the right things for these patients. And that includes, once we get ROSC, doing the things that support perfusion, doing the things that are going to benefit the patient in terms of survival with good neurologic outcome. And my concern is that people are going to start, based on this paper, trying to cut corners to get these scans done within 6 hours. So there's a couple of things here. The first is that I think once you get ROSC, in the first hour or two, and I'm being arbitrary in that timing that I'm stating, these patients are at high risk for recoding. And I think we need to work on stabilizing them, whether that be getting drips up, whether that be getting the A line so that we can see how we're doing with perfusion to improve that outcome. And the second is that we shouldn't be rushing just to get to the CT scanner. And so from a timing standpoint, I think Scott and I agree on this, is that maybe before that patient starts moving up to the ICU, you make like a little pit stop and you go ahead and do the pan scan before they go up to the ICU. So you've done all the things you need to do to stabilize them. You kind of get through that early part of high risk of recoding. You don't cut any corners, but then it really helps the further teams down the line knowing what the potential diagnoses are. So what I'm not saying is don't do these. My concern was this arbitrary 6 hour cutoff of trying to get these pan scans.
Scott, give me your thoughts on this.
Yeah. Well, the first thing I'll say, because I just want to add it to the summary, is what they were doing in this study was not even a pan scan. What they were essentially doing is a triple CT rule out of the chest. And that's pertinent because I think it's going to potentially give additional information that a pan scan would not. So I'll just put that out there. And then to talk about the timing, yes, Sal and I pretty much agree, but we agree in intent. Where I think we differ is I absolutely am on the same page. Don't rush the patient over to CT scan before resuscitation is done, as if this was a trauma patient. Those patients, oftentimes we have this half-hour arbitrary limit. We got to get out the CT. That's not these patients. But 6 hours is a luxurious amount of time for most of the patients I have post-ROSC in terms of stabilization. I mean, we do full court press. They should be getting all their access, all their monitoring stuff in the first, 30, 60 minutes max after arrest. And then they often even have some time to show us, okay, are they really stable or were they just playing with us? And they're actually going to, do some perturbations of their vital signs. But after that, as to whether I'm going to go now, maybe at the 90-minute mark, 2-hour mark, or just wait till they go to on the way up to the ICU is really going to be dependent on what my clinical suspicion is. And, Sal and I, in the conversations leading up to this, we talk about you should have bedside ultrasound there. If I see a big right heart and, the patient's story starts contextualizing towards PE, yeah, I'm not going to even wait till 6 hours. I'm going to get them over as soon as I can get them over safely. If on the other hand, yeah, I don't see anything crazy. Their EKG stone cold normal. They have no signs of PE. Maybe I'm just sending them over there to look for injuries from CPR, and they don't seem like whatever injury they have is life-threatening at this moment. Yeah, there's no reason to rush. Let them happen. So I think it's very patient-dependent. I think if we went back to Sal, he'd probably agree with me.
Scott, there's a couple of things in there that I want to make very clear, too. You said this triple rule out of the chest, so we're looking for a coronary artery occlusion, we're looking for PE, and we're looking at dissection with that triple scan. So obviously that's not what we're doing in trauma. So that's a good point for us to have in the back of our heads. The other thing is you mentioned if you echo the patient, they've got a big dilated RV, I'm going to be pushing to get that CT a little bit earlier to diagnose PE. A lot of people are going to say, well, you have a cardiac arrest and you have a big right ventricle, just go ahead and treat it as PE. But remember that we can get dilation of the RV intra-arrest. And so a dilated RV during the arrest does not mean, or even immediately afterwards, does not mean that there was a PE there. And that's why we want that confirmatory study.
Well, I go a step further and say, sure, a big RV in the setting of after the arrest is settled out, so they're no longer getting the intra-arrest dilation of the right heart. Yeah, it makes you suspect, but we're past that point of like a dichotomous choice of they have a PE and they're sick versus they don't. That's not the question we're trying to answer here. The question we're trying to answer is, where's the clot? How big is it? Is there also clot in situ? Is it going to be amenable to IR? Is this a patient who should get immediate lysis? And those questions can't be answered with your echo. Those questions really require a anatomical delineation of what's going on.
All right, so I want to move over to your second point, which really brings into question the where, as in where do you work? I work in a quaternary center and I can get everything done. I'm not sending anybody out elsewhere. That's not where most of the people who listen to this podcast are working. Many of them are working in single coverage EDs where if you get a patient like this and you get ROSC, you're not keeping them. You're transferring them. And this is one of the points that you brought up in terms of thinking about that scan when you're doing that transfer.
Yeah. And this was like, when I first read this paper, that's exactly the light I was looking at it in. I wasn't looking at it at a big, resuscitation center type ER or ICU. I wasn't looking at it as a trauma center kind of, I was thinking about it more from a community doc's perspective. And so, I work in a lot of community ERs. I work in a lot of what we call freestanding ERs, where it's just an ER, not physically attached to a hospital. And I was thinking about this in terms of my workflow. If I get a cardiac arrest patient at one of those facilities and, Scott's like, oh yeah, we got the team. We're putting our lines in. We're already doing all this stuff. I don't have a team. I have me, 3 nurses, a tech, and a janitor, and a security guard. And oftentimes we're employing the help of the techs to even do CPR at these facilities. And so we're like limited in terms of man and woman power. And so we don't have the ability to stabilize these patients, do all that resuscitation, and then get them over to the scanner in a safe sort of way. And so that was the second point, was like, where does this happen? And I think that this pan scan, sure, if I have a high suspicion of something, I've got the patient stabilized, I have no problem sending them to the scanner. We do have scanners and we have the ability to do that. I was thinking of this more of like think of it, if I could make an analogy, is like a trauma patient. I have a really bad trauma patient, comes to a freestanding or community ER. I'm going to do everything to resuscitate that patient, get hemorrhage control, try and avoid all that trauma-induced coagulopathy. But then really what I'm going to do is, once I get them stabled, I'm going to get them over as quickly as I can to a trauma facility where they can do their pan scans over there. And that's kind of the analogy I make here, is that I don't want freestanding docs who have limited man and woman power thinking that they got to do these scans before they send these patients over to a higher level of care. And that's the point I was getting at with this, is not to not do the scans, but think about it in terms of the environment that you work in, the system that you work in, and really trying to get these patients packaged up, perfusing, doing well, get the access that you need, and then get them over to a higher level facility. And then they can make the decision where they want to do the triple CT, the pan scan, whatever we want to call it, which I know we're going to get into some of the nuance of that later.
Well, it's like the first thing that I ask for is the receiving place when they call with a transfer. Don't bother scanning. Just send them. Because I'm going to do the scans on this end. And by the time you get the scan done and then get the right CD so that you can send it over with, it's not worth the time. Just send them over. We'll get the scans on this end.
I completely agree. And I would just go a step further and say, in the freestanding is not an issue. In the small community shops that have maybe 1 or 2 ICU beds, there's a temptation from some of the hospital administrators. Oh, we could keep cardiac arrests. If they're viable, if they're a patient with a good premorbid state, I would say every cardiac arrest should be transferred. Now, you show me a 90-year-old or a patient who had asystole for 60 minutes and somehow came back, whatever, that we're not going to do anything for those patients. But just the presence of an ICU bed does not a cardiac arrest center make. And so, I think all of these patients should be planned to transfer, and without a CT scan beforehand, except in very unique circumstances.
Scott, I want to talk a little bit about that triple scan of the chest, because this was one of the sticking points that the three of us had. That scan is supposed to be helping to get coronary vasculature. So if the patient has an obstruction of a coronary vessel, that can be taken care of, and also the dissection in the PE. Now, if we have a patient with ROSC, we get an EKG and they have a STEMI, they're going to the cath lab. Do not stop. Do not pass go. That's where they are going. Fine. We're taking out of that those patients and really looking at the patient where maybe you suspect that there's a cardiac cause. Maybe you suspect there's a coronary lesion, but you don't have any evidence. And the EKG isn't speaking to that. And so your cardiologist is going to be like, oh yeah, give me the guy with the stone cold normal EKG who just arrested and now has ROSC. I'll take him to the cath lab. And so this scan ideally would be giving us that information.
Yeah, for sure. Look, remember, we've had a pendulum swing, right? We had only STEMIs got capped, and then the pendulum swang. Swang? That's a horrible sounding word. I don't think that could be
right. You sound Southern, Scott.
You're contagious, my brother. All right. So the pendulum has swung for a little while to every patient with a VFib, VTAC arrest without any other explanation should take a trip to the lab. And there was yield from that. The cardiologists, the interventional guys and gals did not like that. And they put out some evidence saying, no, unless there's a STEMI, you don't need to go. I still think the pendulum needs to swing back a little the other way, that there's a whole group of patients. And, the one that comes to mind immediately are the STEMI equivalents, which we're only now starting to consider STEMIs, but a lot of the interventional folks will not take. Their EKGs I look at and I'm like, this is clearly a STEMI. And they're like, nope, we're not taking it. Well, if you take them to a CT coronary arteries and show them that they have a 99% blockage, then they have to take them. So you're grabbing back a group of patients that might have gotten missed. And, if you look at Steve Smith's blog, there's hundreds now of cases that should have gone to the lab based on the EKG, post-arrest or not, and didn't because they just didn't buy it because it wasn't classic STEMI. So you have those patients. I also think there's probably a set of patients, and none of these are going to be presenting with stone cold normal, but have subtle signs and actually may have a lesion that could emerge to a STEMI 6 hours from now. But if you show them, no, there's an enormous blockage in one of the major vascular paths, then they could take them earlier. So I think it is beneficial. Now, what's the problem? Well, the older scanners many centers have, it's a real pain in the butt to get CT coronary arteries because they really need to be relatively slow on their heart rate. Now, the post-arrest milieu is actually a good one for this because most of them are cold just from being exposed without good circulation. So most of them come in cold, and that makes you bradycardic. So a lot of times they could just naturally, without any augmentation, be able to get these scans. But the new generation, and you might have them at your place, Swami. Most places are going to get them in the next 5 years. The 320 slice scanners, they don't even need a slowed heart rate. They could do it between heart rates, even at the more rapid rates. So as you watch time go on, but we're not talking large timescapes. We're talking like 3-4 years from now. Most places that are like level 1 centers will have the scanners that you don't need to slow a patient down. Because I would not be giving a beta blocker to a post-arrest patient. That does not strike me as clever. And I'd rather just not get the scan, that portion of the scan looking good than, giving the pharmacologic augmentation we did for a patient who's getting CT coronary arteries just because they're coming into the ED for chest pain.
Salim, I think this was one of your major sticking points, was the quality of that part of the scan, of how much information it's really giving you.
Again, so Scott, let me just present you a very common conversation. So patient comes in, they are not a STEMI. We have cardiac arrest, we get ROSC. We do the CCTA and we show that there is a critical stenosis somewhere. And then we call the cardiologist, and the cardiologist's response is, let's wait 24 to 48 hours to see what neuroprognostication is.
All right. That's such a good point here. The reason it's happening, I have some sympathy for our brethren in interventional cardiology. In most states of the union, if the patient dies of the clear sequelae of the cardiac arrest, has nothing to do with the skill of the interventionalist, they get blamed, they get dinged, their numbers look worse, their livelihood and the way the hospital looks actually gets hit. This is a gross mischaracterization of things by the state cardiology boards, and it should just be eliminated. So I feel their pain. If you show them an LAD that's 99% occluded, they're not going to be able to say no. That's it's unfortunate for them, fortunate for us and the patient, is that yes, they could actually do, like, I have many EKGs. I'm like, I would swear on my life this is a STEMI, and they're like, they don't want to do it in this cardiac arrest patient, even though I believe in their soul they believe me. They totally agree. They look at the EKG, they're like, yeah, it doesn't meet STEMI criteria, but it's clearly a STEMI. But they're taking solace in the current thing. It has to be a STEMI in order to go. They can't do that anymore. You can't show them a CT with that lesion and not have them go. In fact, I think this is going to infiltrate into the non-arrest world. And what you're going to have is, when you have the Pendle-Meyer, Steve Smith case of, this is clearly a STEMI, but it doesn't meet classic STEMI criteria, and the interventionalists balk, I think the next move will be to get these patients a CTCA and show them you're wrong, take them, rather than what happens now is we wait an additional 2 hours and have the EKG actually evolve to full-on STEMI that even they'll believe. So I think it's actually going to be, both for post-arrest, I think we're going to see this more and more as we get these better scanners that don't require you to take a sick patient and give them propranolol or metoprolol, which never struck me as very clever. You're going to be able to get the scan done in 10 minutes and just prove the answer that, no, actually, this is a STEMI.
To piggyback off your last point, and you already kind of alluded to this, is we don't all have the 320 slice scanner. And so without a beta blocker, without nitro, the CCTA imaging is going to be very suboptimal. And the authors say as much in the paper. I mean, they admit to that. And then I could see like a response, well, it's an anatomic study, it's not a functional study. And again, trust me, I've had some of these conversations out in the community. I'm not just making this stuff up on a whim. And so I think you need to know the type of scanner you have and how good your imaging is going to be and whether it's worth it to do that. And then the second part of that is like, what's your relationship with cardiology? So we actually, for being a community shop, have really started embracing this OMI versus NOMI as opposed to STEMI versus non-STEMI, because we know that there's going to be some non-STEMIs that need to go to cath lab. I mean, even though they're classified as a non-STEMI. And so we have a very great relationship with our cardiologists. And if we just have a discussion with them, like if I say like, hey, this is a 38-year-old guy who was running triathlons, who had a cardiac arrest, and I'm really worried. I did this CCTA and it shows this like 95% lesion in the mid LAD or proximal LAD. They're going to be more likely to take them. But I could see this conversation happening at other shops where people don't have that relationship. And so I think, one, know the type of scanner that you have and what type of imaging you're going to get. and really start working on that relationship with cardiology, because this is like a pendulum swing, and a pendulum swing doesn't happen in a bubble. It requires multiple parties to buy into it.
The two big things from everything you guys chatted about is one, knowing what your scanner can do. So if you have those 320 scanners, then great. Maybe this is going to be something. But as you are talking about getting those, if you don't have them already, that's the time to sit down with cardiology and say, what are we going to do in these situations? I've got a cardiac arrest. I've got ROSC. I get this CT scan. What are we going to do with that information? If they tell you we're not going to do anything with it, then that will advise you. I don't think that's going to be the answer, obviously, but it's good to sit down in advance as opposed to it's 4 o'clock in the morning. I just got ROSC back, and now I'm having this discussion for the first time, de novo, about what we're going to do with that patient. It's just not the place to do it.
For sure.
All right, so there's a lot that we do agree upon here. There's some stuff that we have a little bit of comms back and forth. A lot of it's going to depend on the imaging modality that we have. A lot of it's going to depend on the quality of the scanner. One of the things, Scott, that you pointed out is that when you look at the group that got the quote unquote standard care, standard approach without that SDCT, the sudden death CT scan, a lot of them got a CT anyway. They got some type of CT. Now, most of it was head CT. It wasn't the full body, but how does that advise the way that we approach these patients?
Yeah, well, that's the real key, because if you were taking these patients and it was just a complete wasted trip, the yield better be pretty damn high. But in almost every cardiac arrest I've seen, they take some trip to the CT scanner, and then you're just leaving potential information on the table to not just do the scan at that point, because that's all the cost for me. I don't care about the monetary cost. I certainly don't care about the contrast anymore for the most part. So what is the problem? It's the logistics of getting them a sick patient there. If you're already going to take them there for something potentially worthless like a head CT in most cases, you might as well, in my mind, just do the rest of it. You're already there. So then it just comes to Sal's point of like, do you take the trip sooner for this than you would otherwise? I don't think in most cases you would. I think at the same time you're going to go for whatever scan the ICU asks for, just make it this protocol and just do it at that point. And then I think most of the cost is gone.
I don't work upstairs. Salim does. And we all agree that the idea of I get the head CT, I send them up to the ICU, and the ICU decides I need more scans and sends them back down, that time investment is enormous. It dwarfs the time investment of us doing that on the front end. So again, this might be something that you talk to your intensivists about and say, hey, listen, I saw this article. This is out there. Do we want to sit down and create a protocol for who is going to get this sudden death CT before coming upstairs? So just kind of agree on it all together. And again, we're playing as a team here, right? It isn't, well, the patient's out of my department, I don't have to worry about him anymore. It's really what's best for the patient and what limits that transport back and forth.
Yeah. And, there's a second RCT out there that you might want to add to the show notes for this episode, but it was the actual ECMO study done by Yiannopoulos and his group down in Minneapolis. And, what I'm talking about now is not specifically about the ECMO portion of it, but they did mandatory pan scans in all of their patients. I don't think they were doing the triple CT. They were already in the cath lab for the ECMO. There was no reason for it. They were just looking for injuries of CPR. And the injury rate was quite high, quite worrisome. Now, it's not directly extrapolable to every patient you have post-arrest, because they were going for like 90 minutes of CPR. They were mechanical. I think the risk of injury increases with each minute of CPR. So their rates probably will not apply, but it is still scary how much trauma is actually induced by CPR. And I think it's going to be the case whether it's by hand or mechanical. So that's another reason why I really like these pan scans. I've been doing pan scans on all my post-arrest for probably 8 years now. And the only new thing this paper really provides is evidence for that triple chest portion add-on. But I've been doing the pan scan, sometimes non-con, just to look for injuries on all my post-arrest patients on the way up to the ICU for that reason.
So I want to piggyback off that, Swami. So the other thing is that, down in the ED, I'm thinking of this from more of a pragmatic logistic kind of standpoint. The patient has less attached to them, so to speak, than once they get up to the ICU. And so a field trip from the ED up to the ICU is much easier to have happen than a field trip from the ICU down to the CT scanner. A lot of these patients have whatever, Impellas, balloon pumps, they're attached to ECMO. There is so much more stuff that has to move with them. And it is not a small feat to move these patients safely to get a scan. The second part of that is like, good luck making the scan happen right then once they're up in the ICU. And so I think from an ED perspective, we need to think of this as like, hey, we're helping the patient and our colleagues upstairs because they are attached to more once they get up there. The second part of that is that I think that, you know, we need to be thinking more, and this is starting to become more of a real thing, is cannulating these patients for ECMO, and getting them to the cath lab. I agree with Scott where the pendulum is kind of swinging back a little bit, because if you say like, oh, they're going to die anyways, well, it becomes a self-fulfilling prophecy. And so we got to get out of that mindset and give these people a chance, and think about it in terms of like, what if this was my family member? You know, what would I want? And so I think getting this done. The third thing, Scott, is I'm curious, because we've thrown a lot of terms around when we say pan scan. I think we all agree non-con head CT. I think for the abdomen, like we do it with the venous phase, or we just do it without contrast is fine. I want to specifically focus on the chest portion of it. Are you thinking that we should be doing triples on all of these if we're already making the trip? Or would you be okay with just like a CTPA without the coronary portion of it? Because I think we need to delineate that a little bit better, because we keep throwing out the word pan scan, and that means something different in the trauma literature than what we're talking about.
Yeah. So to go from a PE study to the triple is really just a matter of adding more contrast and then just protocolizing. So you're not losing anything by going for the triple, except maybe the resolution at the subsegmental level for that PE study will be a little bit less. I depending on the clinical story, would usually make the trade-off to go to the triple, because what I care about primarily is life threats, and the subsegmentals really are not going to be a big issue for me. So I think for most of the undifferentiated arrests, I do like that triple idea. But if you showed me a patient whose story was just so classic for PE, and I just wanted a great PE study, then sure, maybe I'd just go for the CT PE scan. But yeah, what was weird about this study, and Swami, I don't know if you already had this on your notes to bring up, but they also did a venous phase, which I don't think is necessary. I don't know what they were looking for. It wasn't really particularly mentioned. Maybe they just wanted to collect a lot more data and see what panned out. But for my protocol, I would try to keep the radiation somewhat normal, just going with what you want. I don't think they need the venous phase. I'd love to hear from the authors what they were actually looking for with that.
Yeah, I'm glad that you brought that up. I actually have one more point that I want to get to. We're pulling up on 25 minutes, but one of the things that really kind of stuck out to me was the actual primary, secondary endpoints here. So primary endpoint of diagnosis, statistically significantly better, but then the secondary, no difference in mortality. Now, that is what we care about at the end of this, right? A patient-centered outcome as opposed to a diagnosis-centered outcome. If there was even a sniff of benefit in the mortality, I would say, well, listen, we might not get this study done again, or it would be great if we do get it done again, but I would go with it knowing that there was at least some benefit. With no benefit, I just don't see how much of a bang for my buck, and that's probably not the right way to phrase this, because I don't really care about the cost of the CT scan, but I'm not really sure of what the investment of sending him to CT really gives me. If it gives me more diagnosis, but I can't fix any of it, does it really make a difference? And again, we had a very heated back and forth about this, and I want to bring that to light before we close up. Why, Scott, does it maybe not matter that they didn't find a difference in mortality as a secondary outcome in this study?
Well, one of my main points that led us to this discussion was, if you analyze this as a treatment study, it's going to look like garbage, right? But it's not a treatment study. This is a diagnostic study. And they throw people off by chucking in that secondary endpoint of mortality. If I was an author, I never would even put that there, because it leads people to the wrong impression. This is clearly a study of diagnosis. There's a ton, in fact, most, if not all but a few, of our diagnostic modalities that have never been linked to a mortality benefit. So I think that's a pretty high bar to clear. You'd certainly need a much bigger trial. You need much tighter inclusion. Is there a patient-important benefit to this? I think there probably is, but this is not the study that's going to prove it one way or another. Show me the mortality benefit for your pulse ox, and yet how many people are going to practice without that? It's a different way we analyze. Now, if you look at it and you're like, yeah, well, I get these diagnoses, but they never did anything for me. They were just useless diagnoses. They were all like single rib fractures. Okay, maybe I'd argue that doesn't seem important to me, but they found some big stuff here. But yeah, I think it's fair to want their one next level of going from diagnostic utility to actual patient important outcome. But I think it's a bar way higher than we set for almost anything else in critical care.
Well, Scott, also, the other thing is not all cardiac arrest is created equal. And I know this because of the ECMO cannulations and working up in the ECMO unit, you don't just put anybody on ECMO. There's actually a list of criteria that the patient has to kind of meet, because ECMO doesn't really fix anything. It just gives you time to fix whatever the problem is, right? It's a bridge to something. It doesn't actually fix the problem. And my point being is that if you take a bunch of cardiac arrests and don't discern this patient was down for an hour with PEA as their initial rhythm with no bystander CPR, versus the patient who was down 5 minutes, had a shockable rhythm that they got back within 5 minutes. That's the group that I want to know what's the mortality benefit. And when you lump all those together, you kind of get this washout. And so, Swami, I'm not surprised they didn't find a mortality benefit. Although, again, I alluded to this secondary outcome study not powered for that. But I'm really interested in the patients that we do that kind of early criteria of like, what's their lactate? What's their pH? How long were they down? What was their initial rhythm? Did they get bystander CPR? Those are the patients where I think stuff like this is going to be the biggest bang for your buck in terms of getting to that next step. If you lump them all together, you will never find a mortality benefit, because the ones that were down forever that didn't get the stuff that they needed, they were going to die just simply from the neurologic sequela of whatever happened to them during that arrest.
Yeah, I couldn't agree more. What Sal just said is what I meant by I designed the study very differently if I was actually looking for that. And you'd have a very tight inclusion criteria. You'd eliminate all the patients you already had your diagnosis before you went to CT. And in the group you actually want, it would have to be diagnostic uncertainty. And then maybe you'd find something. I don't know if it would even meet the level of mortality, though, because that's a really hard thing to get. Mortality benefit is tough. There are patient important outcomes that come a step below that may be easier to hit. But for me, once I've determined I'm taking the trip anyway, then the patient important outcome kind of disappears unless there was a big risk or cost on the other side, which all of the risk and cost for me is the logistics of taking a patient to the CT scanner. If you're already planning on going, then I think this might be an easy add.
Fantastic. I really appreciate both of you guys coming on and talk about this. I think this adds a lot of nuance that's hard to express in a blog post, but it adds a lot of that nuance to that blog post so that everybody can kind of understand. And I think a lot of this, again, is going to come to talking with your consultants, both your cardiologists and your ICU colleagues, about what their needs are, what's really going to be the best way to approach this, finding out what kind of a scanner you have, what you can get done, coming up with a real protocol together and saying, this is the way we're going to approach these patients post-ROSC. I think that's the way to do this. So I don't think we should be rushing and saying, well, I read a paper yesterday, so I'm going to go ahead and do a full pan CT. You have to really think about this, but that can be done pretty quickly. I think the ICU knows that they get a lot of benefit from doing that CT scan. Get your cardiologist on board too, to really talk about what you're going to do with that information when you get it. And this will be a nice place to move forward. So Scott, thanks for joining us on Rebel EM to talk about this. Sal, thanks for taking the time to chat about it more. Also for doing the peer review on the post. A lot of work and effort went into this, but I hope this gives the listeners a real color and a real flavor for this article and how it can really add and benefit our patients down the line.
And there you have it, Rebel EMers. Leave us your thoughts, comments, and questions. Thanks for tuning in, and until next time.